All right, let's jump right in. You've got a patient with a known cancer, and now they're presenting with new bone pain. A really tough question comes up. What is our goal here, and how exactly do we intervene? In this explainer, we are going to break down the entire surgical approach to metastatic bone disease from the initial diagnosis all the way to a clear anatomy-based treatment algorithm. So let's start with a core concept that honestly can feel a bit like a paradox. This one statement is absolutely foundational in orthopedic oncology because it completely shifts your perspective. It forces you to realize that when you see a malignant bone lesion, the most likely culprit, well, it didn't even start in the bone to begin with. So, the crucial point here is that we're dealing with cancer that has traveled. These aren't primary bone sarcomas. They're secondary tumors that have seeded the skeleton from a cancer somewhere else in the body. And this distinction, well, it's the bedrock of our entire treatment philosophy. It changes everything. That brings us to our first logical question. If these tumors are travelers, where are they coming from? Knowing the most common points of origin is the absolute first step in building a solid differential diagnosis. These are the primary culprits you absolutely have to have memorized. A common mnemonic that works great is BLT with a kosher pickle for breast, lung, thyroid, kidney, and prostate. Seriously, these 5 carcinomas account for the vast majority of skeletal metastases. So when a patient with a known history of one of these shows up with bone pain, metastatic disease should be right at the top of your differential. Let's move on and see how this all plays out on imaging. Once we suspect a metastatic lesion, our main diagnostic tool is the simple radiograph, and it tells a very, very specific story. This is the classic question you're going to get on exams and on rounds. How do you look at an X-ray and tell a metastatic lesion apart from a primary bone tumor? And while it's not always super simple, there are some classic radiographic clues you can look for. Now, what's really fascinating here is that first feature in our table, the periosteal reaction. See, in primary tumors, you often see this robust, layered reaction as the bone actually tries to wall off the aggressor. But with metastatic lesions, that reaction is often really weak or completely absent. It suggests the bone is just being overwhelmed by a super fast destructive process, and it just can't mount an effective defense. And this is a brilliant example of an exception that proves the rule. While most metastatic lesions are destructive or lytic, meaning they literally eat away at the bone, metastases from prostate cancer are often osteoblastic. They actually stimulate new bone formation, which makes the lesions appear dense and white on an X-ray. Totally different look. Understanding these radiographic signs of bone destruction leads us straight to our treatment philosophy. What is our goal when we decide to intervene? This is a paramount concept. By the time a carcinoma has metastasized to the bone, the systemic disease is already advanced. So our primary goal as orthopedic surgeons is not to cure the cancer, but to improve the patient's quality of life. And the most direct way we can do that is by preventing the catastrophic failure of their skeleton. In other words, our job is to anticipate and prevent the break. If a lytic lesion has destroyed so much bone that a fracture is imminent with just normal activity, that is our trigger to intervene surgically. We operate proactively to stabilize the bone before it fails. So how do we decide which stabilization procedure to use? Well, it all comes down to a really simple 2-part algorithm that's based on the anatomy and the tumor's origin. It's a simple 2-step process. Step 1, where is the lesion located in the bone? And step 2, what is the primary tumor it came from? The answers to just these 2 questions guide our entire surgical plan. Let's start with the first decision point. What do we do for lesions located in the diaphysis? The main shaft of a long bone, like the femur or the humerus. This slide shows a really critical fork in the road, and it's based on the tumor's origin. For most tumors, the standard is an intramedullary nail followed by radiation. The nail gives it stability, and the radiation helps control the local tumor. But for metastases from kidney and thyroid cancer, which are notoriously hypervascular and often don't respond well to radiation, we need to do more. We augment that nail with a structural allograft or donor bone to give it that immediate, robust mechanical stability where radiation might just fail. Okay, now let's think about our second decision point. Lesions that affect the ends of the bone, the epiphysis and metaphysis, right near a major joint like the hip or the knee. In these spots, a simple nail just won't work because the destructive process has already compromised the joint surface itself. You can't just bypass the problem, you have to remove it. The solution here is to resect the tumor-ridden bone entirely and reconstruct the joint with an endoprosthesis. You can think of it as a specialized heavy-duty joint replacement that's designed to bridge a really large bone defect. Okay, let's tie all of this together. If you're on call and you get a consult for a potential metastatic lesion, what are the absolute key take-home messages you need to remember? These are the core concepts. First, just remember that metastatic disease is the most common bone malignancy. Your first thought should be to identify one of those 5 primary culprits. On imaging, you're looking for lytic, destructive lesions, but always keep that osteoplastic prostate exception in the back of your mind. And finally, remember that your goal is palliative stabilization, and your surgical plan is dictated by that simple algorithm. Where is it, and what is it? This brings us to our final thought, and it really reinforces our central theme. The answer isn't cure. The primary immediate goal is mechanical. It's to restore stability to the skeleton, prevent a painful and debilitating fracture, and in doing so, maintain the patient's function and quality of life. We operate not always to cure, but to restore function and prevent suffering.